Welcome everybody, good evening. Welcome to the Wolper Wellbeing webinar on optimising men's health from 40s and beyond, hosted by Wolper Jewish Hospital and Friends of Wolper. And our partner tonight is Healthy Male, a national organisation providing information on men's health to nurture generations of healthy Australian men. And indeed, that's our primary focus tonight. My name's Julie McCrossin, and I'm absolutely thrilled to be here to be part of this webinar. Some very quick housekeeping as some more people join us. This webinar is recorded, as we always do, and it will be available shortly on the Wolper Hospital website. And we welcome your questions all evening. You can start putting them in the Q&A area right now. If you look down on the bottom of your screen and click on Q&A, you can put your questions in there. And our question moderator tonight, and we welcome a new question moderator, Dr. Lena Safro. And Lena is a general practitioner practicing in Sydney, and also she does monthly fly-in clinics in Dubbo in Western New South Wales, and she's the chair of the Clinical Governance Committee on the board of the Wayside Chapel. So a big welcome to Lena for joining us. She'll monitor your questions as they come in, and I will go to her at regular intervals during the evening. We put all our questions anonymously so that you can feel free to ask any questions you wish. And I'd just like to extend a very special welcome if this is your first time joining a Wolper Wellbeing webinar. Wolper Jewish Hospital opened in 1961 in Sydney's eastern suburbs. It provides rehabilitation, medical and palliative care services. It's a not-for-profit private hospital with a big focus on quality, and it's open to everyone from all cultural and religious backgrounds. And it does provide some services in the community as well. Well, it gives me great pleasure now to kick the night off by welcoming Simon von Solden, the CEO and a director of Healthy Male, our partner organisation this evening. This is deaf sign clapping, so welcome to you.
Thank you very much, Julie, and thank you everyone for turning up tonight. I'd just like to start by acknowledging the traditional owners of the lands that we're all on tonight, the various elders that have been here before us, and if there's any Aboriginal or Torres Strait Islander people amongst us tonight, thank you very much. And thank you also to the many fathers and leaders that have been there before them, and the information education that passed on about the lands around us. Who's Healthy Male? Probably a good start there. Healthy Male is an organisation that's been around since 2000. It was the vision of one man, Professor David de Kretser, and he saw a gap that no one was educating men about sexual and reproductive health. So we started our life as an organisation called Andrology Australia, and we've moved on from there. We became Healthy Male in 2019, and our aim is to make information available to everybody, absolutely regardless of their age, their gender, sexual orientation, religion, ethnicity, and so on. It's really important to us that information is available to anyone about their health. We're supported by the Australian Government Department of Health, and we also support them. We authored the National Men's Health Strategy back in 2020, and it's the current document the federal government uses as their overarching framework for men's health. So everything we do is to create better lives for men and boys. It's part of our mission to collaborate with the various communities, health professionals, researchers, peak bodies, partner agencies. Evidence is the key to what we do. Things must have an evidence base. So that means that people who come to our website or read our information booklets know that it is a trusted source of information. We also do provide information for health professionals. We have an e-learning platform for them and clinical summary guides. All of that and more you can find at our website at healthymale.org.au. That is enough for me, but we're very excited to be here tonight with the Wolper Wellbeing program and the Optimising Men's Health. Great to see that's being done. There needs to be more of it. Thanks, Julie.
Thank you heaps, Simon. Thank you. And I really commend to our viewers your website, which is, you know, a comprehensive source of information. And I'd too like to acknowledge the land I'm on. I'm on the land of the Kaurna people in the Adelaide region and pay my respects to elders past and present. We actually have people also from Western Australia tonight. It's and Adelaide, so it's a very diverse evening. And look, a big welcome if you've just joined us. Our topic tonight is optimising men's health in the 40s and beyond. And just before I introduce the panel, we'd like to learn a little bit about you. So we're going to do a live poll. So I'll read out the question. We'll give you some time to answer it. We'll look at the results and then we'll move on. So our first question goes to age. And how old are you? 29 and under, 30 to 49, 50 to 79, 80 and over. Please answer that question. Well, thank you. I think most of you will have answered now. Let's see the breakdown of our group. So we have 8% over 30 to 49, 74% 50 to 79, and 19% 80 and over. Thank you very much. We'll now go to gender, please. Are you male, female, or other? And the answer, please. 76% male and 22% female and 2% other. So welcome to you all. Thank you. The next 4 questions are for the men in our audience to answer, and then we'll have one for the women. So this next question, please, about testosterone replacement. Have you ever used testosterone replacement therapy? If you could answer this if you're a man, please. Yes, no, I'm interested in finding out about it. Thank you. With the answers, please. Yes, 2%, no, 88%, and 9% interested. I thought immediately, should I have let women answer that as well, but we'll raise that with the doctor we'll be talking to shortly. Our next question, please, is about health checks. Have you had any of these health checks? Please answer if you're a man. Heart health check, blood test to investigate diabetes, bowel cancer screening, skin cancer check, prostate examination or prostate cancer screening, none of the above. Please obviously answer all relevant, tick all relevant answers. Thank you. So 83% health heart check, diabetes blood test, 68%, bowel screening, 81%. That's I feel like clapping. In fact, I will. I don't know if you can see my hands, but that's great. Skin cancer check, 79%. Prostate examination or prostate cancer screening, 81%. None of the above, 2%. I'll be very interested to hear. I suspect they're very good numbers. Our next question, please, which relates to mental health. Again, I'd ask the men in the group to answer. Various physical factors can have an impact on your mental well-being. Which of these do you engage in regularly? And obviously you can click multiple. Regular exercise, good quality sleep, eat a healthy, balanced diet, drink plenty of water, avoid or limit use of alcohol and other drugs, take time to rest when you're sick or injured, make the time to get a physical or mental health check, none of the above. Well, I think we'll go to the answer. Thank you. 86% regular exercise, quality sleep 76%, healthy balanced diet 95%, drink plenty of water 57%, avoid or limit use of alcohol and other drugs 83%, taking time to rest when sick or injured 64%, and making time to get a physical or mental health check 48%. Look, thank you. We have one last question for our male viewers. Do you perform resistance training, lifting weights 2 or more times each week? Yes or no? I think we can go to the answer. We're skilled by now. 40% yes, 60% no. And our final question is for our women and other gender viewers. Do the men in your family take active steps to keep as healthy as possible and manage any health problems? Yes, no, I need to encourage and remind the men in my family to look after their health. If you could choose the most accurate answer, please. Thank you. Our answers, please. 50% yes, 11% no, and 39% of the women are telling us that they feel they do need to encourage and remind the men in their family to look after them. Look, thank you so much to Nat, our technical operator this evening, and to all of you for answering those questions. It gives me great pleasure now to welcome onto the screen our panel. And for the rest of our session now, we're going to be talking about optimising men's health for 40s and beyond. We're going to be looking at practical advice, key health challenges, and how to try to prevent or at least manage them well, and sources of help. That's our primary focus. We've got 3 panel members, and I'll give you a full introduction when I actually invite them to speak. But let me welcome Dr. Joe Kosterich, if you don't mind waving, Joe, so that people know who you are. Welcome to our general practitioner and industry consultant based in Perth in Western Australia, an adjunct professor at the University of Western Australia, and clinical editor of the Medical Forum magazine, and much more. But welcome to Joe. Welcome also to Professor Robert Newton, an accredited exercise physiologist, professor of exercise medicine at the Edith Cowan University in Western Australia. His research interests include the role of exercise in cancer care and recovery, and indeed exercise as medicine. And he's published over 1,000 scientific papers and attracted over $42 million in competitive research funding. And welcome also to Professor Gary Wittert, who's in Adelaide this evening, as I am. Gary is an endocrinologist, a professor of medicine at the University of Adelaide, and director of the Freemasons Centre for Male Health and Wellbeing, connected to the South Australian Health and Medical Research Institute. And he's published over 450 peer-reviewed papers and book chapters. And welcome to you, Professor Wittert. Can I just ask you, an endocrinologist in a nutshell, what does that mean?
It's a specialist physician who looks after people with problems that involve their hormones, so the endocrine system. And these are protein molecules that are made in one part of the body that circulate and affect other parts of the body. So we look after people with diabetes to do with the pancreas that makes insulin, growth because of growth hormone, reproductive problems related to testosterone or estrogen, and so on.
Just before we go to a major longitudinal study you've done with a very large body of men, and we want to go to some of the key lessons that you learnt from that throughout our panel tonight. But let's go to this question of testosterone and its role in men's health or otherwise, because I think that's something you have clear views on, and it's obviously relevant to your expertise. So what do we need to know about that when it comes to optimising men's health?
Yeah, sort of a targeted approach, isn't it, Julie? Heading straight for the nuts, so to speak. So, you know, there's this myth that exists out there that when men get older, their testosterone levels must of necessity decrease, and that these decreasing testosterone concentrations must be responsible for the sort of what ails you. Fatigue, difficulty with sleep, sexual difficulties, and so on. So the reality is that, in fact, these are parallel processes, and while they appear to be related, they're occurring separately from one another. So the same things that cause testosterone to go down simply occur concomitantly with the aging process, and that's an accumulation of disease burden mostly related to obesity, not exclusively, but substantially. And there are other factors like certain medications and certain other lifestyle factors. And those factors in and of themselves are responsible for many of the things that can occur and afflict people that are attributed to decreasing testosterone. The reality is that if people maintain good health, they're lean, they're fit, they're active, they have regular physical activity, they're not depressed, they have a good relationship, they're not drinking too much alcohol or using opioids, they're going to age with a perfectly normal testosterone level.
Okay, so is there any role in testosterone replacement therapy for men's health?
If you have a disease of the system that makes testosterone, leaving you with what we would call pathological hypogonadism, so that is a circumstance where testosterone is required. In all other circumstances, what is required is a thorough evaluation to determine the state of health and to find what disease process is responsible for any abnormality of testosterone that's determined. And if a low testosterone is found, by implication, a cause must be found for it. So what I see in practice all the time is testosterone gets measured, but none of the other checks that should be done to determine the cause occur at the same time. And then very often people are given a prescription of testosterone because it must be good for you. And then I see them when they feel that it's not really benefiting and dealing with the issues that they want dealt with. And that's a very important problem that occurs because you have people who are meaning to do well by their own health that are not getting a fair go by the system, in my opinion.
Again, I will come to your study later, but when we spoke earlier the other day, you said, Joe, you feel that every GP should ask two questions. One of them is to men, when we're talking about men's health, and one is, are you having trouble with erections? And the other is, are you getting up to pass urine at night more than once? Right. Just in a nutshell, why are those two important questions? And I might come for an opinion come next to our general practitioner.
Well, firstly, those questions are very quick to ask. Secondly, they are questions that men want to be asked. And we know that from a national men's health study that was done under the auspices of Andrology Australia, now Healthy Males. So we know what men want to be asked. And we know that men aren't asked those questions. The reason they're important is because those two symptoms associate with a considerable burden of the risk factors for the common chronic diseases: obesity, diabetes, cardiovascular disease, hypertension, obstructive sleep apnea, depression. So if an answer to those questions is yes, then there must be a significant underlying problem. And then you're able to help men with something that they really, really care about. And they're going to be more likely to engage in treatment than if it's something that doesn't mean anything to them. And the second issue is both of those symptoms predict future disease. So if you have a male with erectile dysfunction, they're more likely to get heart disease, a heart attack or angina in the future, or a stroke, or diabetes. And the same occurs if you have significant frequency getting up at night to pass urine. Much the same outcome might occur. Now, while there are some nuances to this and some other factors, grossly speaking, that's the package.
Okay, look, thank you. I'm going to come back, obviously, Professor Wittert, but let me welcome now to the screen, to our audience, Dr. Joe Kosterich. And as I said, Joe is a general practitioner and industry consultant based in Perth in Western Australia, and also an adjunct professor at the University of Western Australia and a clinical editor of the Medical Forum magazine. Just before I come to some other issues with you, Joe, what do you think of those two questions? Are you having trouble with erections, and do you get up more than once at night to pass urine? Are there any more you'd add to the list?
Look, first of all, for people watching, if you're wondering about the background, yes, I've been in the surgery this afternoon and it's going to take too long to get home to get all this done. So hence the unusual background. look, I mean, Gary's right, but the point is, as a GP, the endocrinologist has two questions he wants you to ask. The asthma guy has, the kidney guy has, like every specialist has two questions that the GP should ask. And you've only got a certain amount of time. You don't actually have 3 hours to see every patient. So no, you can't ask everybody every question that every specialist wants asked. So it is a more targeted approach rather than we're going to ask everybody every question that everybody thinks should be done. But look, certainly erectile issues are tied in with a whole host of other issues and can be the, in inverted commas, canary in the coal mine. For example, with with diabetes can be one of the early signs, can be a pointer to anxiety or depression or other mental health problems. So it can point in a whole host of directions. And look, again, Gary's point is correct that typically lower levels of testosterone aren't going to occur in isolation. That said, again, it's also, we could say to people, well, you don't need medications for diabetes or blood pressure, just lose weight and exercise. And some people will, but some people will still need medications. So I suppose more people get prescribed testosterone than Gary would probably like, and perhaps really is ideal. But you could say the same thing for a whole host of conditions where we use medications because for whatever reason, people just don't either quite do what ideally they could, or they do it and they don't quite get there. And again, looking at the replies in the questions, Julie, I suspect we've got an audience that is already perhaps at the healthier end of the spectrum, which is that's good, and they're investing the time tonight to learn more about their health.
That's right, and these wellbeing webinars have been going for quite a number of years, so there is a body of audience that have had the benefit of meeting a lot of people. But can I just ask you, just before I leave the testosterone question, can you just give us a sense of for what sort of situations you would prescribe it, just so we're clear on that?
Yeah, look, it's very, very much individual circumstances. And I suppose it's what's for sometimes called, and this is getting into more controversial areas. There was a British doctor some years ago who coined the term called grumpy man syndrome, which is essentially men probably 40 to 50 plus, most typically with a constellation of fairly non-specific symptoms. They're tired, they're grumpy. Often the partner is saying he's grumpy, reduced libido, usually tired, maybe overweight, a whole loss of interest in what they're doing. And in amongst other things, then they may well have testosterone levels that are sort of maybe not low, as in technically below the cutoff, but just sitting on that lower edge. And those ones, look, in the first instance, it is about, look, what we can do to raise these levels more naturally. Can we get you doing some exercise? Can we look at mental health problems? Can we do all of those things? Sometimes they need almost like a bit of a Kickstarter. And for some of those people, they may be prescribed testosterone. I've seen it happen. I see Gary shaking his head, but it happens. Yeah. And that sometimes gets them kickstarted. And sometimes they will shop around until they find somebody to do it. And sometimes it does them some good. And sometimes they come back with their tail between their legs saying, well, you were right the first time, doc. We really should have tried lifestyle measures first. So there's never a one size fits all. It's a meeting of, I suppose, and sometimes a compromise between perhaps what the textbooks and the guidelines say and what's going on with the person in the real world. And look, sometimes people do quite well with it. I've seen that happen, and sometimes it's entirely inappropriate and shouldn't be done and needs to be stopped. And
thanks, Joe.
It's very much an informed discussion.
Thank you very much. I will come back to Professor Wittert just because he did shake his head, and this is clear we may have a difference of opinion, which we will share with our audience, and they will reflect and take it further with their own clinicians if needed. Do you want to just comment, Gary, just because you were shaking your head?
Yeah, I mean, firstly, we have guidelines. They're very well crafted. They're agreed to by the RACGP. They were published in the Medical Journal of Australia. I see these kind of patients every day that I practice clinically, which is twice a week, and they don't need testosterone. They need to have the underlying disorder found, which mostly we can do. And as to the grumpy man syndrome, it's profoundly discredited. If you look at the evidence, you cannot tell the difference on a symptomatic basis between the men with a normal testosterone and men with a low testosterone, or relate the level of testosterone to the symptoms. So it's alchemy. it's guesswork, and I don't think that it's appropriate clinical practice in any way, shape, or form.
Well, look, we've got a strong difference. I'm going to move on, if I may, because I think our audience can deal with that, but a very interesting interchange, and thank you. I'd like to welcome Professor Robert Newton now, our accredited exercise physiologist and professor of exercise medicine at Edith Cowan University in Western Australia. Look, I know a major focus of your work, Rob, and there's already been reference to the importance of losing weight and being lean and being active. And you're very much about exercise as medicine. Our audience always want practical advice, and all arrows in your world are pointing to exercise. Could you talk to that, please? What you mean by that, exercise as medicine?
Oh, certainly, Julie. The human body produces enormous changes in our physiology when we exercise. I mean, dramatic production of hormones and cytokines, other molecules that signal every other tissue in the body. And so when we exercise, we get this production of endogenous or internal medicines, which are highly effective and very, very powerful because they're the natural signals, chemical signals that our body produces to regulate all our systems. I think it's very interesting, the discussion around testosterone. It is a major problem that we do see, and as Gary's pointed out, very much it's a change in body composition of the Australian male population, higher fat levels and low muscle levels, low levels of physical activity, and higher stress levels and anxiety and other issues, and that's creating huge hormonal imbalances within the body, creating a very unhealthy status. And certainly, coming back to that, I think exercise is very important, but what we do know is that resistance training, lifting weights, has a far higher stimulus to testosterone. So it's not just going out and walking the Dalmatian or playing a hit of golf. That's important. Any exercise is better than none. Most of the Australian male population is sedentary at the moment, which is a huge driver for our chronic disease burden. So any exercise is better than none. But certainly for those men where testosterone is an issue, they need to be lifting weights because the evidence is overwhelming and very well-controlled trials that will cause an acute stimulation of testosterone, and that will help to fix a lot of problems. So that's just one example of exercise producing medicine in the body.
That's what I was just thinking. Can you give us another specific example? Because that is so interesting.
Our team at the moment is doing a lot of work around cancer and how exercise actually reduces the progression of various cancers. And we've known for a decade or more now that people who are physically active that have cancer have a much better survival, but in particular, they have better cancer-specific survival. So the question that is begging is, well, how does exercise actually alter the trajectory of their cancer? We know that exercise reduces risk of dying of heart disease or diabetes or a whole range of other chronic diseases, but how does it actually influence the biology of the tumour itself, the cancer? And so we're spending a lot of time now looking at various mechanisms. We're just published a paper published today, actually, in prostate disease and prostate cancer and prostatic diseases, and in that, what we showed was that men with advanced prostate cancer, when they do an acute bout of exercise, they get a surge of these molecules released from their muscles, are called myokines, and these myokines have a cancer suppressive effect. This is quite exciting because the men is producing their own anti-cancer drugs, if you like. And that's quite apart from all the other mechanisms whereby exercise supercharges the immune system and activates the immune system internally to fight the cancer as well. And so that's exciting work. And what we actually did, we took the blood from these men after they'd exercised, and we actually separated the serum, the fluid portion, and we poured it over live prostate cancer cells. And we saw about a 20% reduction in rate of growth. So there's something when we exercise, marked chemical changes which occur, which actually signal cancer cells to grow more slowly.
I'm a cancer survivor myself, so I'm listening with great intensity to what you're saying. And if I could just say, one of your messages is be physically active on most, if not every day. And I'm going to come to you, Joe, in a second, because I know you have a very similar focus as well, because I know people are thinking, wow, about exercise, but of course it's how often and how much. Could you answer that, please, Rob Newton, and then I'll come to Joe for his perspective.
Well, it's easier if you spread the exercise over multiple days for a start. You know, it's pretty hard if you go out and run a marathon on a Saturday. You're going to be pretty sore and sorry. It's just easier. We find that compliance is better if you just recommend to the patient, just do 20 minutes of resistance training and some aerobic or cardio training, as some people call it, just each day, and try and get it most days. The other reason is that you're dosing the body with these exercise-induced medicines each day. So each day you're normalizing your endocrine system, your hormones within your body. You're helping to make the body more responsive to insulin, for example. A major problem in Australia is insulin resistance and the development of pre-diabetes and type 2 diabetes. But this small amount of exercise each day just helps to increase the muscle's ability to uptake glucose, be more responsive to insulin release, and it really helps to balance it out and counteract it. So that's why we're recommending that people should try to exercise most, if not every day, so that they dose themselves with this endogenous or internal medicine.
Well, thank you, Joe Kosterich. If I could come to you, your key message when we spoke was it's about what you do every day that matters, what you eat, how you move, and your sleep. We haven't yet heard from sleep. I'm interested in, I guess, how responsive you find your male patients over time, because the great thing about GPs is you see us over years. So, you know, these messages come through in almost every one of our webinars. How responsive are most people in your experience, and what leads to success in doing this?
Well, there's a lot of work done about the different stages of where people are, from sort of pre-contemplative right the way through. Look, I've never even thought about doing this, to right the way through to I'm doing it. And people are at different points of that, you know, different points of that spectrum at different times. Look, and you're right, in general practice, you get a number of bites at the cherry, and you can remind people and you can prod people. And well, I'd say over the years, sometimes people have done nothing, and then one day they come and say, oh, you know, I've decided I'll finally do it, and I've decided to do what you told and suggested I do, and I've done it. It's also about trying to keep it as simple as possible for people. And the word exercise, look, I think it's good. Like, you know, go to the gym a couple of times a week and go running, but it has certain connotations, and people immediately think, oh, you know, I can't do it. It's too hard. I've got to go buy some equipment. So I think that sometimes it's about telling people to be active. Now, active can be taking the steps rather than the escalator or the lift. Active can be, I'm going to park further away from the entrance to the shopping centre rather than. So there's been quite a bit of work done on what's called incidental movement. And a stat which has really stayed with me over the time is that it was estimated that between 1965 and 2010, the number of calories not burnt up through, for example, not having to get up and change the TV channel, not having to get out of your car to open the garage door. And that's a good thing. You know, if it's raining, I don't want to get out of the car either if I don't have to. But all the labour-saving devices, essentially it's about 2,000 calories per week. Now, that's one day's amount of calories over a 45-year period from a whole lot of labour-saving devices. So there's a lot you can do to incorporate movement just into your day. It's amazing to see people queued up for an escalator when the stairs are empty. It's like, you know, I get some people, it's difficult for them. Sure, everybody is different. But look, to get back to your question, in my opinion, it's about trying to make things as simple as possible for people. And rather than giving them a fixed number, like one of my pet hates these ads that say, find 30 minutes. Great. What happens if you can't find 30? Oh, well, I won't do it. No, 10 is better than 0, 20 is better than 10, and 30 might be better than 20. But when it becomes too prescriptive, people think, well, it has to be that, and if it isn't that, then they do nothing. So a little bit is good, a bit more is better, don't overdo it. But it's really about just trying to get people to think that, you know, your ancestors had to be active, they didn't have a choice. You've now got a choice, and you've got to make that choice to be active. Sure, you don't have to get up to change the TV channel, fantastic. You don't have to get out of your car to open the garage door, great. But you need to make up for that.
Yeah, no, thank you. Look, ladies and gentlemen, thank you for joining us this evening and for sending us questions. I'd like to invite Dr. Lena Safro to join us on screen. Hello, Lena, good evening and welcome to you. Can you give us a question from the audience, please?
Sure, just to follow up on what Joe was just saying, someone wants to know about the role of exercise in slowing down the progression of dementia. What's the evidence?
What I might do, if I may, is come to Rob Newton first as our exercise physiologist. Rob, what would you tell us there?
Yeah, look, as an overall comment, people who are more physically active, there will be a delay in the onset of dementia. Quite a large study was done in monozygotic twins. So these are identical twins. And what they did was they compared one twin who was physically active through recreation or through occupation versus the other twin who tended to be more sedentary. And what they showed was around a 10-year difference in terms of the onset of Alzheimer's. So there may be other lifestyle factors associated with that, but that's probably the strongest study to date.
Look, thank you. And Professor Wittert, if I could come to you and if I could just alert people that you were the initiator and lead in a major study, I think of over 2,500 men, the Florey Adelaide male aging study. And there's a number of things that come out of that. And I want to come to that in a moment, but let's go to this question first of exercise and dementia prevention.
Well, from the point of view of general cognitive function, people who are physically active have better cognitive function. We didn't particularly focus on that, but there are a number of studies that show that. Similarly with healthy eating, and both healthy eating and physical activity are independently associated with better mood, less depression. And then importantly, as a motivator for men, physical activity is excellent for sexual function. It improves erectile dysfunction. It's been very clearly shown to do that. And independently, healthy diets have been shown to improve erectile function, and they both improve sexual function. So again, when trying to motivate men, I try to use what they care about most.
Yeah.
And so, you know, if people are going to pick one thing to do, I agree entirely with Rob. Resistance activity, because you can do that at home. Much of it sitting in a chair. It's not weather dependent. It's not a buddy dependent. Doesn't require going to the gym. Very powerful message.
And Professor Wittert, you believe this idea that men don't seek out help through healthcare is actually a myth, but that how you communicate is important, and that you like to see men first alone because they can be very blunt with them, and then if they have a partner, they can be useful later. Can you just speak to that, your approach to communication?
So, you know, we saw you commented on the interesting stat when you polled the people who've come to listen tonight, and you saw the very high proportion of men that had been to screen for disease. And we've got a broad spectrum of ages that are in the webinar listening tonight. And that's very good evidence that men do care about their health. They do seek out healthcare, but they like to do it in a different way. And on the basis of that, in fact, Healthy Male, originally done by Andrology Australia, updated by Healthy Male, a guide for primary care docs to deal with men. So men like to be communicated with directly. They don't like to have to wait for appointments. If they ring up and they want to schedule for something and it's 3 weeks away, that's off-putting. They like to be asked the questions directly. If they go for something, say a knee or a cold or throat or something, they won't ask the incidental health things the way women will. And so every one of those opportunities is an opportunity to, in my opinion, to screen for disease. However busy a doctor is, there's always time to chat a little bit in the process of dealing with a problem. And so I think taking the issue directly to men, not waiting for them to volunteer their information, and then scheduling back in a timely way to work through this issue. But it's demonstrably incorrect that men aren't interested in their healthcare. One interesting stat from a paper we recently published, and very similar data comes from the 10 to Men National Health Survey, which is younger men, is that men who have a high burden of depressive symptoms use primary healthcare services, in other words, visit their general practitioner considerably more frequently than men without a high burden of mental health symptoms. And yet only half or less of those men actually get referred on for appropriate care or get a diagnosis and treatment.
Okay, look, thank you. I'd like to come back to our question moderator, Dr. Lena Safro, if I could. Lena, another question, please.
Yes, somebody would like to know the panel's opinion of the so-called long life pills, such as antioxidants.
Antioxidants. Okay, thank you. Joe, would you like to explain what an antioxidant is and your thoughts on them, please?
Yeah, it's going to be controversial again. I mean, antioxidants are typically sort of like vitamins A, C, E, zinc. There are a few flavonoids that come in, for example, green vegetables, blueberries, strawberries, green tea, and they mop up what are called free radicals. So imagine an apple sort of goes brown after you've cut it open and it stands there for a little while, it's oxidizing. And, you know, you see rust on metal, again, it's oxidizing. And essentially in the body, no, the body's not going to rust, but it can also be subject to what's called oxidative stress. Now, again, people argue the toss on this, but the idea of antioxidants is it mops those up, so it's therefore useful. I don't think it's an anti-aging pill. I'm not sure there is such a thing. And again, in an ideal world, and that's the world that doesn't exist in guidelines or government departments, in an ideal world, everybody would eat enough fruits and vegetables and get all the vitamins and minerals that they need from their diet. When I last checked, it's not an ideal world, so not everybody does. And maybe they should, and they should be encouraged to, and all of that is great. But after all of that, antioxidants can be useful for some people, and they find them beneficial. Now, maybe for some people, that is also a bit of a placebo effect, and if it is, it's an extraordinarily harmless procedure. I'll put my hand up. I take a multivitamin every day. And I also take a probiotic every day, and I feel quite good. Now, maybe I'm imagining it, but you know what? It's not doing me any harm. Should everybody take it? That's a personal decision. Not everything that everybody does about their health has to be prescribed. Not everything has to be medicalized. We actually medicalize too much of life. If somebody wants to take an best eat fruits and vegetables. That's the best thing to do. But if you don't, or you're not eating enough, then you can take an antioxidant, and if you find you feel better for it, good. If you find it makes no difference, stop taking it. It's not an anti-aging pill, though.
Look, thank you. Professor Rob Newton, do you want to comment on that?
My think is pretty much aligned with Joe's opinion on that. Fruit and vegetables, definitely the way to go. One of our top professors here at ECU, Amanda Devine, she's also done a lot of work which shows it's very important to source those fruit and vegetables as close to your home as you possibly can. They need to be grown and not transported very far. Don't buy oranges from the other side of the planet. They're months old, and of course, a lot of the nutrients are lost. So, and also it's very important because if they're grown locally, they have the correct mix of bacteria, which will help your microbiome as well. So my recommendation is, it's also a lot cheaper to eat fresh fruit and vegetables as well. As long as you eat them in season, you don't want to get oranges in the middle of summer. Yeah, you're going to pay a fortune for them, and they're going to come from California. So it's also important that you work with the seasons. I mean, we've been designed that way, that as the seasons change and the fruit and vegetables change that are available, you roll with that. And that's also very important for health.
Okay, yeah, Gary Wittert, if I could come to you, we enter pharmacies these days, and there is a sea of products that are complementary things like antioxidants. And I think you referred earlier to the changing body composition of Australian men, and that the reduction in muscle and increase in fat. I mean, that's the dilemma. These diet messages are, again, very common in our webinars. I know diabetes is your field. Is there hope here in terms of, I guess, a change in the body shape occurring for some of the patients that you deal with, or is this an individual thing, or is it to do with our dominance of two supermarkets? What's your analysis?
Well, the people who change their shape most effectively have adopted a program of regular physical activity and changed the way they eat. Now, I don't like the notion of diets. I think that the conceptualization of obesity is pejorative and leads to stigmatization, and it's problematic. And I don't talk to my patients about weight loss. I talk to my patients about achieving better health, and people can do that at any weight. Now, no one wants to feel bad. Everyone wants to feel great, and everyone wants the quick and easy way to do it. Give me the pill, I'll take it. If I'm going to feel better with a pill, I'm not going to bother with the harder stuff. And I think that we fail as a society and abrogate responsibility to our doctors to educate patients when we don't do that on a public health basis. We really ought to have health programs that start in the early years of school and teach young people health literacy and health competency so that they understand the reasons for adopting certain practices. I have a young child who nags me about my driving endlessly, but will never say anything about his brothers stopping to buy jam donuts. And it reflects the sort of education that's occurring in the classroom. And so I think that, and of course, you know, young people are very good at having designated drivers, and so education works, and education influences parents. And I think we need to really look at that, as well as the supportive environment where we're actually regulating things like soft drinks with taxes, so that we can encourage changes in behavior as a result of social pressure, much like has occurred with smoking, rather than trying to get change based on the responsibility of general practitioners and other doctors trying to cajole individuals to make these changes. But if we're going to make important changes to our shape, we need to start very early. If you look, and my kids get annoyed as I walk behind families taking photographs, but the point it demonstrates is youngsters 5, 6, 7 taking on the shape of their parents very early on in life. And, you know, one of my colleagues, Nicole McPherson's doing some wonderful work, and we're co-supervising a PhD student who's looking at how sperm carries unhealthiness down to the next generation. And it's very clear that that occurs. And it's very clear that weight is not the entire story. It's healthful behaviors that underpin this. So it's a kind of long story that gets back to the fact that I think we're getting the messaging wrong. I think we need to have a very simple, cohesive message as healthcare professionals about what a healthy diet means. And that needs to be reinforced recurrently. And we need to make sure that the messaging and the education is done much earlier and not left to healthcare professionals later.
Look, thank you. Rob Newton, you've been nodding madly there. Can you tell me why you're nodding?
Look, I work a lot with people who are overweight and obese. It is exceptionally difficult for them to lose weight. You know, all of the approaches, bariatric surgery, some of the new drugs which have come along, they work in some people, and some people they don't. And they have a whole lot of other problems that occur with them. I think it's very important to recognise that any dietary restriction, whether it be through bariatric surgery or through appetite suppression, is difficult. It does cause, in the main, some fat loss, and can be quite substantial fat loss, but it also causes muscle and bone loss. My concern is that we have an ageing group of Australians who are going to be osteoporotic and sarcopenic, and the burden on the health system in caring for these people is going to be catastrophic.
Rob, I just need you to explain your terms. So if you could explain bariatric surgery, osteoporotic, and the sarcopenic, I think it is.
Oh, I'm sorry, Julie, I got overexcited. Yeah. So I mean, many people unfortunately are turning to surgery. Gastric banding or other procedures by which reducing the size of the stomach so they simply can't ingest as much food. And many of my patients find ways to get around that. And also there's a new range of drugs now also that are strong diet suppressants. They're being used in type 2 diabetes at the moment relatively effectively, but people have also found that they lose fat mass on it because it suppresses appetite, and recent papers come out showing a lot of side effects as well. The problem with it, any of these strategies to reduce fat mass are also muscle and bone loss strategies. Every study has shown this, that the patients will also lose muscle and bone. And this is a major problem as we age, because one of the major issues we have with the aging population, because we're less physically active throughout life, is that many more percentage of the population is sarcopenic. That means they have very low muscle mass. Now, this leads to dysfunction and disability, and these concerns place a major impact on quality of life. I do want to just really touch on an important point that Gary made regarding the characteristics of behaviour of the male and female parent around the point of conception. Interesting, very important research from Gary's team and others around the world showing for the first time that the dietary intake and the physical activity patterns and behaviours of the parents actually alter the genetic expression in the offspring. And those genetic changes are permanent. And it's natural adaptation that you get born into the environment of your parents. So genetically, in the past, that's been an advantage. If you had to live on high fat because you're in the Arctic and you had to eat seal meat, it was an advantage if you developed that genetic expression. But that's a problem now because a lot of Australians eat high fat, high salt diets. So the offspring automatically crave and take to those foods. And that's driving a lot of our obesity problem, and why Gary sees in families that unfortunately the 6-year-old has the exact same body shape as the mum and dad.
Look, I have a number of issues, but let's take a couple more questions from our audience, if we could. Dr. Lena Safra, if I could ask for more questions. Thank you.
Yes, thank you. Still on the diet, someone is saying that many people eat a healthy diet, but have difficulty gauging what the healthy serving size should be. How do you go about deciding what that is?
Look, thank you. Can I come to you, Joe Kosterich, because you must deal with this with your patients as a GP a lot.
Look, an analogy that I often give to people is a big 4-wheel drive is going to use more petrol than a small Kia or Hyundai. So they both get you from A to B, but one is going to need a lot more petrol than the other. So different people need different amounts of energy to get them through the day. We're not all the same. We really are not all the same. It sounds so obvious, but there's an assumption that there's the one size fits all is going to work for everybody, and clearly it doesn't. So people really have to find the level that works for them. So if what you're currently eating, like if people are wanting to lose weight, if what they're currently eating is not having the desired effect, then what that says is that is enough for what the body requires, which in turn means that to reduce weight, you're going to have to take in less calories. Now you can say, well, what's your portion? What's your current portion size? Try and cut it by about 10 or 15, %, something like that. People can get quite technical and weigh their amounts of food. Now, often that's a bit of a pain for people, so they won't want to do it, longer term. But look at what you're currently eating. The most useful thing for people, I find at times, is to keep a diary for a week of everything you eat and drink. So it's not an exam. There are no right or wrong answers, but you can see what you're actually doing, and that gives us a start point. And the other trap for people is that as they do get lighter, if they do lose weight, then as they get lighter, they don't also need as many calories. So what maybe got you from 100, I'm plucking these numbers from the air, right? From 120 to 100 might not get you from 100 to 90 because you've now lost 1/6 of your body weight. You're not as heavy as you used to be. The body doesn't need as much energy. And one of the most fascinating graphs that I've seen is in a book called Big Fat Surprise. By an American science writer. Her name's Nina Tykol, so you can get it on Amazon. It's a fascinating book. And this graph shows weight over time, and it's a fairly flat line, and then there's an inflection point. And that inflection point was when low-fat dietary guidelines were introduced. And yes, we don't want too much fat in the diet, but the problem is low-fat foods typically have the fat removed and replaced by sugar. So they're often worse. And Gary will be an expert on this in terms of insulin. When people have foods that have got carbohydrates in them, it causes insulin to be released. That's what's supposed to happen. But insulin stores the carbohydrate as fat. So you immediately put your body into fat storage mode. And that's often why intermittent fasting works for some people, because they get into ketosis, they get into a ketotic state. That's why Mike Mosley's 5-2 diet is very helpful for some people. Again, everybody's different. You've got to find what works for you. And for other people, the 16-8, where you only eat within an 8-hour window of the day, because then it kicks the body into a ketosis state, and ketones means you're burning fat. Ketones is a byproduct of burning fat. That's great. That's what you want to be doing if you want to lose weight. And obviously, as Rob says, doing some exercise, because you want to be reducing the body's fat content, not the muscle mass. So by doing particularly resistance exercise, you can better maintain that that muscle mass. But the start point is always, what are you doing at the moment, and what effect is it having? And if it's not having the desired effect, then that's the start point that we need to move from.
Look, thank you. Let me come to Gary Wittert, because diabetes is your world, isn't it? So how do you approach this portion size issue with patients?
So look, portion size probably does matter, but it doesn't matter as much as some other factors do. And my starting point is always the nutritional quality of the food, because eating less of a nutritionally suboptimal diet, in other words, eating less of the wrong foods, is not going to be good for you even if you lose weight. And Rob's made that point extremely well, why that is the case. So the first thing I do is look for the sugar drinks, because that is a major contributor to excess calories and it's unnecessary. And that includes fruit juice, which many people believe is healthy. The second is snacks. Now, there are only some people who need snacks, and those are small, rapidly growing children, pregnant women, very elderly people, athletes, and hobbits. So for those of us who don't fit into any of those categories, we don't need snacks. So that's the second thing that goes. And the third thing that goes, if people have not categorized it in their conception of drinks, is alcohol. Alcohol is a major contributor to weight gain, and it also wrecks sleep. Even a small amount of alcohol changes the EEG patterns and disrupts sleep. And I routinely give this advice to men, and I've yet to have anyone come back and tell me they don't feel considerably better in every respect, and they lose a lot of weight. So for me, that's the starting point. And then finally, to Joe's point about processed foods, I have a simple rule that I give people. Now, if I was smart about this, I'd make complicated rules. I'd write a book and I'd retire. But I'm not smart enough to do that because it would only be half a page. And it goes like this. Don't eat processed foods. And the way you decide about processed foods is when you put food on your plate, ask 2 questions. Before it was on my plate, was it growing somewhere? And before it was on my plate, was it with its mother? And without thinking too hard about Skippy, that gives you a pretty good guide about what to eat. And it doesn't require complex sessions with dietitians and big books with guidelines. It's a very simple approach. Now, Joe makes another important point, which is about what I call eating architecture, which is eating in sync with a normal circadian rhythm. So it's not appropriate from the way the body works physiologically to eat after dark. And that's because we have clocks. Every cell has a little clock in it. And the way our cells work depend on the time of day. And some of those processes need to work at night and repair the cells and recover from generating energy in those processes during the day. And if we're eating at night and forcing them into the energy process, they can't undergo growth and repair. So restricting your food intake to a reasonable portion of the day, limiting to meals at breakfast, lunch, and dinner, roughly at regular times, and eating healthy foods which are non-processed. Really, when you do that, it's quite hard to overeat. The body finds that the nutrients are satisfying, and people are not running for snacks or eating extra on their plate. Finally, there's this idea, and there's a whole industry around it, that if you take fantastic fruit and vegetables and you chuck them in a device that smashes them into a liquid, and then you add all sorts of powders, that it's got to be good for you. And actually it ain't, because the liquid form of food empties from the stomach very rapidly. And that gives you a very big spike up of insulin. It also increases inflammation and leads to accumulation of weight. It's far better to drink water and not smash the food to a liquid, eat the food properly.
Thank you so much, Gary. And interestingly, in our survey tonight, that was one area where the numbers were low, wasn't it? The drinking of water. Rob Newton, your thoughts on alcohol and sleep?
Not
necessarily connected, but those two topics that connect them.
I just want to add 2 things that, again, I hark to our Professor of Nutrition, Amanda Devine. Her recommendations to her patients are, if it comes in a packet or a can, don't eat it. The second one is try to use smaller plates because your meal looks bigger. But try how many colours can you get on your plate? And that just, those simple, as Gary says, this is not rocket surgery. It's just these simple changes. Absolutely. Look, it's not my area, to be honest. But, I agree 100% that I see this a lot in my patients, is they're having trouble sleeping and they're having trouble losing weight. And then when you don't sleep, it interferes with your hormonal balance, and then it makes it more difficult to lose weight. but definitely alcohol has a huge influence in terms of your sleep quality and quantity. And it is an issue that I encourage my patients to address. We don't I don't push them all to be teetotalers. That might be a bridge too far. But we definitely have a good discussion about cutting the alcohol down, having it if they're drinking every day, to try and introduce alcohol-free days. And if they can do that, then to extend that more and more, so they have more alcohol-free days in a given week. And then also try to look at things like dry July and things, and then have extended periods of, say, a 4-week period where they don't consume alcohol. It is a major problem for so many different health issues, but it does definitely interfere with, does contribute a lot to the overweight and obesity issue that we have in Australia.
Thank you. Joe Kosterich, how do you approach the alcohol issue in your practice? And I might come to Gary as well. I remember when the NH and MRC, National Health and Medical Research mob, put out their guidelines on recommended alcohol levels. You could almost hear this snort of derision across our nation, because people just thought the quantities were so low, they must be joking. And yet, as someone who's done a bit of work for the Cancer Council, they tell you there's no safe level of alcohol use. So how do you deal with that in your practice with people, particularly with men I'm talking about here?
Yeah, look, I mean, the start, like before, with what people are eating is how much do you drink? And typically the answer is, I drink socially. Well, that's fine. It means nothing. And I say this to the medical students when they're in with me, socially means nothing. What does that, how many, how much, how often? Once we can get actual numbers, then we can start to work with that. And then it's sometimes about, what do they think? Sometimes people sheepishly sort of don't want to say it because they actually know it's a little bit more than they should be having. And sometimes people say, look, have a couple of beers on the weekend when I'm watching the footy, and that really is about it. And look, there's no point giving those people a lecture. It's not a problem. There is such a thing as enjoying life. And look, I'll put my hand up. I quite enjoy a glass of red wine. And to be honest, I've got no plans to completely stop it. So again, one has to be reasonable. I would, there's very, very little in this world where there is no safe level. I mean, arsenic is in trace elements in some fruits, and it's a poison. So these sort of comments from some of these organisations, there's no safe level. And I think probably it applies to smoking, but that's about the only one. It puts people off. I don't think it helps. You've got to find the level that works for you. And, to follow on from Rob's comments, it's like, find out what's currently happening and reduce it down, and then see how you feel. If you feel better, it's a bit of a no-brainer. Like if you've cut down from 4 drinks a day to 1 drink every other day and you feel better, people are going to continue to do it. It's getting to make that start. The other point I was going to make about the foods, and Gary's completely right about processed foods, and I actually did write a book some years ago, Gary, and no, I haven't been able to retire, unfortunately, where one of the things I said is eat foods that basically resemble how they started out their lives. So in other words, until fairly recently, they've been growing somewhere or moving around somewhere. And by the way, if you don't eat them this week, you probably have to throw it out next week. You can put it in the pantry till 2024. Probably got a lot of preservatives and additives. And the other really simple tip for all the people listening is a lot of supermarkets are configured in a fairly similar way. So you've got around the perimeter of the supermarkets, typically the fruits and vegetables, the meat, the deli section, the frozen goods, the dairy. And in the aisles are all the biscuits, the breakfast cereals, the soft drinks, cat food as well, I suppose, and washing powder. But in terms of foods, if you shop around the perimeter of the supermarket, you're probably 3/4 to 4/5 of the way there, and it's fair. And again, it's fairly simple. People don't, generally don't drive into the petrol station in a car that runs on 98 and put diesel in that car. They just wouldn't do it. Like, why would you? But we often go to the supermarket and put into our trolleys. We're doing that in equivalent. So yes, you can still go to the supermarket. The supermarket is not the problem. But if you're already in there, it's no more difficult to buy some carrots than it is to buy some cornflakes. And by the way, if you want cornflakes, just buy some corn on the cob instead. It is far, far better. So it's those simple things. If we can make life simpler for people, and I think often the message is, rightly or wrongly, just people switch off because it just seems too hard. If we could make it simpler for people, not everybody's going to do it, but I think a lot would, or at least they'd put their toes into the water.
Look, thank you. And I just want to get a quick comment on the alcohol issue from Gary Wittert, and then I'd come back to our question moderator for some more questions from the audience. Your thoughts on this issue of alcohol and men's health?
Yeah, look, it's a complex topic. I mean, I think I agree with what Joe said. My general feeling about it is there's no safe threshold for alcohol. Many men regard alcohol as an essential component of their ability to socialize. There's a lot of culture that's developed around alcohol, but there's also a lot that underlies violence out in the streets, during the day, motor vehicle accidents, other accidents, and domestic violence that's grounded in alcohol consumption. So there are social issues, there are medical issues, there are economic issues associated with this. And I think it needs a whole of society approach to take a very careful look at it. I don't expect anyone to necessarily be a teetotaler, but I do think that if people are making the choice to have alcohol, they ought to know in detail what the risks are and the very limited benefit that might accrue to some people.
Thank you. Dr. Lena Safro, let's have some more questions from the audience. Thank you.
Thank you. So changing the subject a little, someone wants to know, for a man aged 79 years, what's the normal number of times he should expect to go to the toilet at night?
Oh, golly.
The answer is one. The answer is one. More than one is abnormal.
And so what would you be recommending, Gary, if someone is going to the toilet more than once, a man's going to the toilet more than once at night?
Get a check and find out why. If I ask a room full of people, how many get up at night to go to the bathroom of the men, there'll be a large number that put up their hand. If I ask them how many think it's due to their prostate, then they'll all put up their hand. And in women, there'll be a similar number who get up at night to go to the bathroom. And if I ask them whether they think it's due to chronic infection, cystitis, some complication of pregnancy, then they all put up their hand. The reality is that in both men and women, the causes are the same. And unless there are very severe flow symptoms, so obstruction to flow, then getting up at night to pass urine is a sign of disease that's got nothing to do with the lower urinary tract. It's simply it's caught up in the process and gets reflected. So things like high blood pressure, abnormal cardiac function, so even early heart failure, obstructive sleep apnea, depression is strongly related. Abnormalities of blood glucose even before diabetes becomes overt. Inflammatory conditions, insufficient physical activity, insufficient fiber in the diet, they're all very strongly related to nocturia.
So you're basically saying look for underlying conditions if you're urinating more than once a night.
Yeah, it goes to the point. It goes to the point Joe was making before about the specialists all want us to ask their questions. To which I would respond: the two questions I'm putting up for consideration cover everything, and so they're your essential pan question, the holy grail of questions that cover everything.
We actually, I think, have a question about erectile dysfunction, don't we, Lena? If you could help us with another question, please.
Yes, thank you. So quite a few people would like to hear about erectile dysfunction.
Okay.
What it is and what are the management options.
Look, thank you. Can I come to you first, Gary, and then I might come to Joe
Sure.
as a, I might come to each of you for a comment. Thank you.
When I ask men about erectile dysfunction, and many men will come and talk about libido, they'll talk about sexual function, and I need to be very clear whether they're talking about desire or whether they're talking about the mechanics of erection. Now, when it comes to mechanics of erection, it's hydraulics. You've got something that pumps fluid in, it causes extension of a tube that has the capacity to fill with the fluid, and it's got a system of valves which are made out of muscle that stop the fluid from flowing back out. And this is all regulated by stimuli that go to the brain, nerves that go from the brain to the penis, and touch that goes from the penis back up to the brain. So young men will get erections from visuoerotic stimuli, but older men need more stimulation to get an erection. It will often require more touch, more interaction. It will not just occur easily or spontaneously. Testosterone is not absolutely required to get an erection, and the absolute level of testosterone can be quite low before erections are lost. But it varies a lot between individuals. So there's a very poor relationship. Testosterone is much more closely related to sexual desire than it is to erections. So where you get down to is defects in the hydraulics. And it's usually the same process that's associated with blood vessels that where you get high blood pressure or coronary artery disease. Very similar processes occur in the vessels. They're not dilating properly to let the blood flow in. And that could be the vessels themselves, the signals in the nerves, which could be damaged because of diabetes or so on. So mostly an abnormality in an erection is reflecting a disease process that's causing damage to blood vessels elsewhere, or is part of a systemic process causing damage to nerves, in general terms. And very often the process starts very in a progressive way. So the first thing will be losing an erection. Well, possibly the erection is not as firm as it was. They may lose the erection during intercourse so that they can't quite get to orgasm every time. And then it may be that the erection is not firm enough for penetration. So there's this typical sequence of events that occurs during the process of erectile dysfunction. Now, most of this can be very effectively treated, but it's also a chance to reevaluate lifestyle factors and see what can be leveraged. And my experience working with men is if you cut to the focal point, you get an awful lot of cooperation.
And can I just ask you, because we have a lot of older people watching tonight, can erectile dysfunction or change in erections just be associated with just plain old aging, or does it always indicate an underlying problem?
Almost always. It's not normal to lose your erections if you maintain excellent health. There are studies of tribes that live in remote communities that are free of systemic disease. There are studies of Okinawa centenarians who live up to 100 years in this archipelago of Japan, where they maintain excellent health, and they do not lose erectile function to any significant extent.
Gentlemen, I want to do something on sleep apnea and also prostate cancer, just core messages before we finish. But would either Joe or Rob like to comment about erectile dysfunction before we leave it? Anything additional?
Look, I think Gary summed it up pretty well, that they're separate, and the two are not completely separate, but yes, libido as in I want to have or I'm interested in having sex versus erectile capability, which is the mechanics or hydraulics works. And yeah, often the latter, is tied in with variably diabetes, high blood pressure, a whole host of conditions. One additional point, though, that does matter can be psychology. And certainly for men, if they have problems with erections and then they start to worry about erections, then it can become self-propelling. So that can also be an issue. And to get back to what you were saying before, look, alcohol is and can be a problem too. The term brewer's droop, haven't heard about much recently. It's an old one for the obvious reasons. So that can be a spur. And just touching on that subject, for some reason, I think Mediterranean cultures get it right in terms of how they deal with alcohol. And in the Anglosphere, we tend to separate drinking from everything else we do. In the Mediterranean cultures, they don't. They take longer to eat. They eat as a big group. It's social. They might have a glass of wine or so. It's part of the Mediterranean diet, but it's not a separate thing. They don't get out to get drunk. So it's a different cultural approach. So yeah, we could potentially, although unfortunately we don't tend to, we could certainly learn from the cultures that get it right.
Look, thank you. Rob Newton, any comment on erectile dysfunction? You've indicated exercise is useful.
Certainly, Julie. So we published several papers now, and a lot of this work was led by Professor Prue Cormie from our team. She's now at the Peter Mac. But what we found with men with prostate cancer was that, harking back to Gary's point, is that erectile dysfunction or sexual health is a major concern for them. It's front of mind. I'll never forget presenting at a conference once. It was a prostate cancer conference, and I talked about cardiovascular risk, and a whole bunch of men and their partners came up to me and said, "Oh, look, Prof, your talk was semi-interesting, but you're not addressing the real issues we face." Oh, geez, dying of a heart attack. I thought it might be fairly important, I thought to myself. But they said, no, sexual health and urinary incontinence. Yeah. Nothing else, everything else pales into insignificance. These are the factors. So we launched a program of research. So to get back to the point, what we found was that men with prostate cancer, if they've had prostatectomy, they might be on androgen suppression or testosterone drugs.
Now explain the words. Just explain both words, please.
So they've perhaps had their prostate removed, which can cause erectile dysfunction because it may damage the nerves. But also they may be on androgen suppression. So in other words, taking drugs which drop their levels of testosterone to castrate to practically zero. And as Gary's pointed out, this does cause a loss of libido because testosterone has a factor there, an effect there. What we found was that the men reported that the exercise increased their desire for sex. It gave them more libido, and in part was because particularly weight training, lifting weights with a group of other men, made them feel more masculine. And so harking back to Joe's point as well, it is very much, it's 50-50 in terms of the physiology, but the other huge part of it is the psychology and their mental health and approach to it as well. So we found that resistance training in particular was very, very helpful in improving sexual health, mainly through increasing libido, sexual desire, and just overall confidence and masculinity of the men.
Could I just say, for anyone who may be watching who is affected by prostate cancer, I've done a number of conferences with many hundreds of men who are survivors, and the prostate cancer nurses cohort that work with these men who were present at this conference are fantastically good at talking very frankly and bluntly and with, excuse me, humour and warmth about sexual practicalities. And it's important to know there are important sources of help and hope because, of course, we haven't mentioned suicide tonight and we don't have much time left, but we do have to be careful with later life and some conditions where depression and suicide can be a risk. I mean, that's the bottom line. Did you want to say something, Gary?
Yeah, no, look, I agree with what's been said about the psychology of these conditions. I was made aware recently by a urology colleague where they had seen a man, I don't know what sort of age group this gentleman was, but was diagnosed with prostate cancer and he was due for surgery. And in the lead up to the procedure, he unfortunately took his life. And it goes to highlight how important it is we give people about the fact that this is not the beginning of the end of a catastrophic quality of life. And in fact, there are ways that sexual function can be dealt with and improved substantially. There are ways of maintaining relationships satisfactorily. But I think we also have to be mindful that the psyche of people play into all chronic diseases. So people with diabetes can get depression, and depression makes diabetes worse. One of the things that's very likely to cause a recurrence of symptomatic cardiac disease is anxiety and depression. We did a meta-analysis showing that. So we always need to think about our patients with chronic disease and ask the question, is there also a mood disorder or an anxiety disorder at play? And think about really the interplay of the psychological and the physical, which of course is very difficult to do and complicated. And we don't necessarily always have the requisite skills to do so, but we do have a system where we can write mental health care plans and tap into allied healthcare professionals who do have those skills. And so that's a big strength. And so for many patients, they should be knowing, I think it helps them to know what's out there and raise their expectations about what can be provided and work together with whichever kind of health professional is responsible for their care to seek out solutions rather than accepting that there's nothing that can be done.
Look, thank you, Rob Newton. If I could come back to you on exercise here, because I've heard it said if you walk with a group of people in nature, that generates a huge preventative focus for anxiety, depression and loneliness. But you probably know something more about even the biological impact of exercise. But exercise and mental health, just what's the evidence there?
Probably the classic study here was done by Professor Nailan Singh, who unfortunately passed away recently at the University of Sydney. And what that group showed was they took a group of older people and they had a clinical psychologist evaluate them. And those that were clinically depressed, they then put them into one of three groups. The first group was told, look, you have clinical depression, go back and see your GP, and they received routine GP care. The other two groups, one group did low intensity resistance training, so lifting light weights, and then the third group did lifting quite heavy weights. Now, they got about a 25% reduction in clinical depression symptoms in the routine GP care, but there was around a 35% reduction in the group that did light resistance training, and they were doing it in a group format. So just the fact that they were doing exercise with light weights with other people, other older people, elderly people, really had a therapeutic benefit for their clinically diagnosed depression. However, the group that lifted heavy weights in a group format had a 60% reduction in clinical depression. Now, the reason is, of course, that they are interacting in a group, and as you say, walking and getting out in nature and things is highly beneficial and therapeutic. But there is something about lifting heavy weights which causes most likely endocrine responses within the body, brain-derived neurotrophic factor, endorphins, a whole range of other hormones and other molecules, which actually have highly suppressive benefit in terms of depression and anxiety.
Wow, is what I say to what you just said. Lena, can we have one last audience question, and then I might get something quick on sleep apnea from Gary Wittert.
Sure, just very quickly, for a man that has proven low testosterone level, how difficult is it to access treatment?
Gary, can you turn on your mic?
Yeah, the answer is that if you have pathological hypogonadism and you meet the criteria, it's very easy to get it. It should be no problem at all. There are guidelines for prescribing and using testosterone effectively. No issue at all.
Okay, thank you. Just a quick word on sleep apnea, what it is, and it's linked to cardiac dilemma, heart problems or other matters, please.
Yeah, so what it is when you go to sleep, there are mechanisms that work to keep your airways open so that you can breathe, so that they don't collapse down. Now, if they partially collapse, then you get a snore, which is effectively air passing across soft tissue, there's all the stuff in your neck, collapsing down together, and the air causes it to vibrate. So that vibration is what a snore is. Now, if the collapse is sufficient to block the flow of air to the extent that the level of oxygen in your blood falls, then that's called a hypopnea. And if the collapse is complete, then that's apnea, so nothing. So hypopnea is low, apnea is nothing. So under those circumstances, oxygen is dropping. Now, it can occur a little bit in people, but when it's severe, it occurs up to 30, 40, 50, 60, I've seen 90 times an hour, which means for most of an hour, you're not getting much oxygen. And it causes inflammation. It's linked to high blood pressure. It's linked to cardiac disease and stroke. It's linked to diabetes. It's strongly linked to depression. It's linked to cognitive decline. It's linked to motor vehicle accidents, impaired work performance, so accidents at work and difficulty doing the job. Linked to anxiety, very strongly linked to sexual dysfunction, both desire and erections, and strongly linked to low urinary tract symptoms. It ain't a good thing. Oh, and it's linked to cancer. Recent data has shown very strong links to cancer. So this ain't a good thing to have, and it's extraordinarily common. So in our study, which involved 860 randomly selected men in the northwestern suburbs, 1 in 2 men over the age of 40 had some degree of sleep apnea. And in half of those men, it was moderately severe, so 50%, so 25% overall. And in half of those, it was very severe. So that was 12.5%. And in about 12%, they weren't particularly overweight. So there's a strong genetic component to this. If a parent had it, you're likely to have it. And the final point I'd make is that a lot of people think that sleepiness needs to be present for significant sleep apnea to be there, but actually it turns out that sleepiness is not a good sign of severe sleep apnea. It's more related to lack of physical activity, being overweight or obese and having depression.
Look, we're right at the end, and I'm a great believer in finishing on time, but just literally a moment response to this one, Gary, if I may. I think we've all seen the sort of scuba gear that gently blows air in to allow things to get a better airflow and less snoring, and it's helpful. In your experience, how willing are men to wear them? I mean, do most patients accept them because it's going to prevent all those things you've listed or help prevent?
Well, often they're very reluctant until they've tried them out. One of the problems, of course, is that if people believe that it's going to help their sleepiness, then they find that it doesn't help their sleepiness, then they're reluctant to persist for the amount of time they need to feel better. And really, it's not the treatment for sleepiness. Sleepiness may be a factor, and it may improve, but often it doesn't because of the other things. And with deference to Rob, the single non-technical intervention for improving sleep apnea is resistance activity. Resistance activity has a very strong benefit to reduce the severity of sleep apnea.
Look, is everybody else going to go now and get some weights and do them before they go to sleep? I'm going to go and lift my cavoodle a few times with each hand. Look, gentlemen, we've reached the end of our time. I'm sorry I didn't have time to come back to you, Joe, but I just really want to thank Professor Gary Wittert from Adelaide, Professor Rob Newton from Western Australia, and also Dr. Joe Kosterich from Western Australia. And thank you very much, Dr. Lena Safro, for your work tonight. Can we all just do a deaf sign clapping to thank everybody and our audience for joining us this evening? And it was delightful to have Dr. Lena Safro as our question moderator. A survey is going to be emailed to you very shortly. We do ask you to fill it in. They really do read them and adjust the topics and the format in response to what you say. This session has been recorded and will be available on the Wolper website within a week. And the Wolper Wellbeing program for next year, 2023, is in development right now. And I'm told you will be able to check the Wolper Hospital website or the Wolper Hospital Facebook site early in the new year to see the topics and the dates. And so a big thank you to our team, and wishing you all very well for the holiday season. I hope you're getting a holiday. And it's goodbye from me, Julie McCrossin, and thank you so much for taking this interest in men's health tonight. Thank you very much.